Hello again. This is Alan Winter with my colleague, Dr. Art Gleiner, and we're going to talk about um, continuity of care and reflect on how the care of Steve Jobs and his denial of care for 9 months, how it impacted his outcome, and see how that might be considered today. The comments last week was by Mr. Christopher John Fryermuth, who, who said, before patients can accept difficult medical decisions, a trusted primary care physician can prepare the patient, help interpret recommendations, and continue the conversation when fear and uncertainty lead to hesitation. Continuity isn't just coordination, it's stewardship. So with that thought, today we're going to talk about stewardship of a patient from the physician's standpoint, but also about how the health system has an impact on uh, patient outcomes. So I think today we think about health systems as being efficient and throughput and revenue capture and risk management, and not so much about personal continuity of care from the standpoint of seeing your personal doctor. The structure has separated the patients from their doctor in a number of ways that we're going to discuss, making continuity and the relationship issues of today's health problematic. I think one of the clearest examples is scheduling. In many employed settings, the scheduling is no longer controlled by the physician. It's instead of the physician's staff handling it, it's done by a pool that's centralized and follows system-wide rules. The expensive physicians, of course, are scheduled as far in advance as possible to maintain productivity and make sure that their salary is covered. And a person who wants to see my doctor, may be told the next appointment may be months or weeks away. So technically, you might have a doctor in a health system, but they're functionally unavailable. So that's a real issue that's become more common. Wouldn't you agree, Art?
Yeah, absolutely. And the other point about this is that when you're looking at costs, you have to look at, first of all, whether there are additional cost burdens that the whole system has to bear because of some miscommunications or inefficient use of resources that are embedded in the way that patients are scheduled, and who bears those costs, because oftentimes the health system will be able to bill the insurance company for the costs, but for as a global cost incurred for an illness, the global cost that's incurred may be much larger because of inefficiency in the way the patient is handled within the system.
Certainly. So I think we can consider if you have an urgent problem, then it becomes even more difficult, because a new symptom creates anxiety in the patient. They want to be seen, not a month from now. But so as a result, they call up and the patient might be sent to an urgent care center or a same-day clinic, or to the emergency department, or to another clinician in the same network. And often that clinician is a nurse practitioner or a physician's assistant, but they're not being seen by the doctor that knows them best. And the patient who sees someone else is doesn't understand the patient's prior illnesses, and the social context, the medication history, uh, preferences that patient has for different things. So it's in a sense the visit access has weakened the therapeutic relationship.
Yes, I had a friend who relayed after listening to the recording that we made a week or so ago about Steve Jobs, and she got back to me. She said, "I want you to know that the problem is much worse than as you described it. I got reassigned to a different primary care physician by my organization without them ever letting me know about that. And they made the appointment, first of all, for a time that I couldn't make, and I had to reschedule the visit. And then when I showed up for the visit, I caught all kinds of flack from my new primary care physician who had no relationship with me at all. He gave me a very difficult time about my changing my appointment. And then he proceeded to sit in front of his computer and not make any eye contact with me during the entire visit. And I said to him, "Could you please look at me while while you're having a conversation with me?" He said, "No, I can't. I need to be looking at the computer because all your information is there." And she protested that the relationship was not a very good one or a very satisfactory one for her. And he proceeded to tell her that if she didn't like the care that she was getting, he would discharge her from the practice and she could go find another doctor. So the
That's terrible. That's terrible.
there are multiple costs that are incurred in that kind of relationship problem, and all kinds of information and relationship that are lost that would benefit the patient and the physician both. But it really doesn't benefit anybody for that kind of disruption in relationship to occur in order to satisfy the rules of the system.
Right. The system has rules supposedly to improve efficiency, and what's happened is that it's affected the doctor-patient relationship negatively. But if you just analyze what happened there, since the patient's original primary care physician was gone, um, most likely, and we can pretty much tell this because of non-compete clauses and employed physicians contracts. The primary care physician probably didn't like the rules either, or the loss of relationship with patients. So that person decided that they couldn't work in that organization any longer, and so they decided to leave. And because they had a non-compete clause, they had to move 50 miles away, and because their contract specified that it was a non-disclosure about them leaving, they couldn't tell the patient they were leaving, nor could they. So the patient just thinks the doctor disappeared, and then they're assigned just arbitrarily to another provider, which
Right.
which in itself was a negative as far as the patient was concerned. So that, like you said, it's worse. The the system of continence is worse, even in Steve Jobs' day,
Yes.
in a sense. So so it used to be that the physician schedule was a clinical tool. I mean, and not just a business tool, which is what it is now. Um, the physician would answer the phone, or I mean, would hear about a patient on the phone that needed to be worked in. They'd be worked in at lunchtime, or the physician's schedule would leave some blank spaces every day for patients that would just call in the same day. I know we did that. Commonly, we would leave 7 open spaces on Monday, 6 on Friday, uh, 5 on Wednesday, 4 on Tuesday, and 3 on Thursday, to show you what the likelihood of people calling would be. And that way we could see those types of patients. That never happens anymore. The schedule is always full. they don't take that same day patient. Instead, they send them to somebody else who, as you noticed, looks at the chart the whole time because they don't know what to do.
Yeah. Disrupting the trust that patients have with their primary care physicians or with any of their physicians has always got to be a counterproductive thing to do. And yet the systems don't seem to recognize that the cost of that and who bears the cost of that. Because down the road, when a patient needs to be given information that's uncomfortable or that they may not be completely on board with, you're running into an extra cost and an extra disruption in terms of trying to convince the patient about what's best for them.
Oh, clearly. I mean, if you don't trust the doctor who's telling you something, you're certainly not going to go along with the recommendations. I mean, 30% of prescriptions aren't filled. I mean, there are various reasons for that, but I got to feel that your patient receiving treatment from the clinician that you described after he just threatened to throw her out of the practice probably is going to be I mean, she's going to go home and read the internet before she takes that medicine.
Right.
I mean, her level of trust in that.
Or follows any advice from that physician, right?
Yeah, I mean, it would have been much better for her to have been told about the fact that she no longer had her primary care physician. Maybe they could have scheduled her annual exam at least to come meet the new primary care physician. Um, that's a sad that's a terrible story, but it's so typical of healthcare today, where the patient and the doctor are really irrelevant to the system. Um, uh, so scheduling is one issue. Then of course they've uh, the the urgency of sending people to sometimes urgent care. Health systems build more urgent care centers than they do primary care centers because the urgent care can function more hours, I guess, and you can get an extra fee, a facilities fee, for going to urgent care that you don't get if you go to a primary care office. So from a financial standpoint, it makes more sense to do that, open urgent care.
Except that somebody has to bear that cost. And so eventually it's either the insurance company has to bear that cost and they in turn have to pass the premiums on to an employer or somebody else. It can't be free to build more urgent care centers as an excuse for not having good primary care. That can't be a good trade-off for the system as a whole.
Well, see, the costs are irrelevant because nobody's paying them. It just gets passed along, and ultimately the system bears it, and nobody sees the cost because nobody's seeing that cost in real time. So then I guess you have to think about um, the health system capturing all those costs. So the less familiar the doctor is with the patient, the more tests they're going to order. And that's clearly true about clinicians that don't have the background of the patient and would would tend to order tests much faster, more referrals. But then from the health system standpoint, that's good because they have more revenue. So the
Right.
system is working just as designed. You want to maximize the illness costs and minimize the benefit to the patient, which is striking. I mean, it's like, is this a healthcare system or an illness care system?
Right. Right.
And uh, with with the integration of all the system is good from the standpoint of it can improve communication and the shared records can coordinate care, but it certainly doesn't improve fragmentation because nobody's in charge.
Right.
I mean, who's in charge of your just continuing your patient who was treated by the not primary care physician, well, who who's managing that follow-up care?
Right. And it's hard to say who was going to be responsible for that, but you can see that there's just got to be more inefficiencies in the system, and somebody has to bear that cost. It has to be more expensive to do it that way.
Well, it's clearly true that the more you delay um, proper care by being uh, um, bounced around to various uh, uh, different offices, perhaps, and until the correct diagnosis is made, the greater the greater the cost. I mean, look at the cost in the of Steve Jobs. Had he been directed through the process in a way that was that a way that addressed his denial, and we're going to talk some more about that uh, uh, in the next session. But look at the cost. I mean, a Whipple procedure probably would be around $100,000, but when you consider a a liver transplant and all the medication, that's close to $1 million. So, and then subsequent years of anti-rejection medicine are hundreds of thousands of dollars. So, so it's almost penny wise and pound foolish to not have the correct care at the earliest possible time.
Right. Just for people who may not have seen the previous discussion that we had about Steve Jobs. Steve Jobs had a cancer found that he did not have treated and in a timely fashion, which ended up requiring the liver transplant down the road. And that entire cost was an additional cost to the system, whoever paid it, of over almost $1 million for something that could have been avoided possibly had he had the proper treatment to begin with, and had he had the relationship that would have enabled that proper treatment.
Exactly. So the continuity of care is just part of it. I think the comment from the session by our reader about stewardship sort of is demonstrated by all these problems that we've elucidated today in terms of access. Just having access to a physician is really not the most beneficial way to have health care.
Right.
You really need somebody to be a steward of your health.
Right. And the people in the system have to be aware of what the additional costs are, whether they bear them or not. There has to be there are no feedback loops that give the information back to the people who caused the disruption of the care to begin with, right? So
Right.
in the case of my friend who went to see a new physician, the person that she saw, I'm sure, had no feedback at all about the consequences of what his actions were in his relationship in disruption with her. I mean, I don't, and what we don't even know what the downstream costs might have been incurred because of that disruption in that relationship. You know, that remains to be seen.
Right. She's going to be less likely to call um, that clinic, I would think.
Yeah. She doesn't ever want to be seen by that clinic again, but she may not have a choice because of insurance reasons and employee relationship issues that have to do with how she gets her healthcare insurance from her employer. But again, the employer is not even included in that equation as well. The employer has no idea what's going on and why their choice of how they provide insurance for this employee of theirs affects their bottom line. So all of the consequences of this kind of behavior are not accounted for because nobody ever gets feedback about it.
Right. There's virtually no feedback in the system. And, and as a result, the system just remains in the way that it's designed. It's functioning perfectly. It's exactly what's expected of the system. The system is meant to be as an illness care system rather than a healthcare system. And you judge it as an illness, and you try to generate as much revenue from the hospital standpoint as you can, and the insurance company tries to deny payment as much as it can, and it just goes around and around as the price continues to escalate, and there's no end in sight to it.
Right. And unfortunately, the improvements in technology that provide better healthcare tend to mask and cover up the fact that healthcare is becoming more costly and less efficient in the case. Because even though we're doing a better job of providing care for people because of the miracles of modern medical care, the costs are much higher than they need to be, and the satisfaction is much lower than it needs to be on the part of patients.
Oh, without a doubt. Your friend is an example.
As we talk, I'm more and more struck by the fact that there really is no system to be had here. Nothing that's really identifiable as a system. It's all a bunch of little things that are patched together. And it's that disruption is costing. I think there are several different costs that are being borne here that are invisible to most users. So many people have insurance now that they're not bearing the costs directly themselves. So that gets hidden, it gets tucked away. The dissatisfaction costs are enormous, and the lack of compliance that it engenders with patients has got to be taken into account as well. So there's at least 3 costs that aren't being accounted for by the way healthcare is currently being conducted. And there may be more. And maybe things I haven't even thought of that are being borne by the system. And it's getting hidden. Nobody's paying attention to it because nobody, it's not costing anybody out of pocket.
When you consider most patients had a doctor 30 years ago, today, only 17% of patients have a doctor. So that tells you the difference in terms of stewardship as as it relates to medicine. So the system is clearly a problem with regard to care, and I think we saw that in the instance of Steve Jobs, and I think we'll continue to look at some of the issues that affected his outcome. So, Art, thank you very much for this session, and we'll plan to do another session next week.
Sounds great.
Okay, bye.